Hi, this is Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on today's video. On today's video, we're continuing with our new and ongoing series entitled X-rays and Medical Research in the QME evaluation. And today we're in session number 5. And in the first 4 sessions of this program, we've talked at great length about the necessity of ordering diagnostic studies for your complete evaluation of your examinee. At least in chapters 15, 16, and 17, the AMA guides require x-rays for the assessment of impairments of the spine, of the upper extremity, and of the lower extremity. And one of the principles that I want to really drive home with this program is that the evaluation and the examination that we're conducting and performing as qualified medical evaluators in the qualified medical evaluation is substantially different from the examination that we would do in our clinical practice. In the qualified medical evaluation examination, we're evaluating the examinee for the presence or the absence of impairments. In our clinical practice, we're examining our patient for the presence or absence of a diagnosable condition for which we can render treatment to hopefully alleviate the symptoms associated with that diagnosed condition. So in the qualified medical evaluation, the permanent impairment evaluation has the distinct purpose of assessing the examinee for the presence or the absence of impairments. Not the presence or absence of diagnosable conditions. By the time the examinee gets to us for the permanent impairment evaluation, he or she has already been diagnosed. He or she has already been rendered medical treatment. The permanent impairment evaluation has the express purpose of assessing the examinee for the presence or the absence of impairments. It's a bit of a different take and a bit of a different philosophy. But many qualified medical evaluators don't quite get or understand this distinction. So if the purpose of the permanent impairment evaluation is to assess the examinee for the presence or absence of impairments, it becomes of paramount importance that you know what are the impairments for each of the particular body parts. So in chapter 16, the spine chapter, the spine has specific named impairments and specific elaborated impairments in chapter 15. For example, muscle guarding is an impairment. Non-verifiable radiculopathy is an impairment. In chapter 16, the upper extremity chapter, loss of range of motion is an impairment of the shoulder. Loss of strength to resisted manual muscle testing is an impairment. Resection of the distal clavicle is an impairment. In chapter 17, there are 17 different impairments for the lower extremity alone, and you need to know each and every one of those impairments. And when you have an examinee come in with a lower extremity industrial injury and you are performing your permanent impairment evaluation, your obligation is to assess for all 17 of those impairments. And next to each of those impairments in your report, you're going to check a box that the examinee either has that impairment or that impairment is absent in that particular examinee. Okay? So if you understand this idea and this philosophy, you'll realize that in assessing the examinee for the presence or absence of impairments, diagnostic x-rays are required because in chapter 16, one of the impairments of the spine is a loss of motion segment integrity of the individual spinal vertebrae, and this can only be assessed on flexion extension radiographs. So therefore, with your spine injury cases, every single examinee needs to have flexion and extension radiographs so that you can assess for the presence or absence of permanent impairment due to loss of motion segment integrity. In chapter 16, one of the impairments of the upper extremity, mostly involving your wrist injury cases, is carpal instability. Well, carpal instability is assessed on specialized non-routine views of the wrist, non-routine radiographic views of the wrist. So when you have a wrist injury case, you absolutely are required to assess the examinee for the presence or the absence of carpal instability. In the lower extremity, one of the impairments of the hip, of the knee, of the ankle, and of the foot is post-traumatic arthritis. So many times, examinees who have had a knee injury go on later to develop sequelae of post-traumatic arthritis of that joint as a result of the industrial injury. So we're required to assess the examinee for post-traumatic arthritis. They either have it or they don't, but we're required to assess for it. This is assessed on X-ray studies through the measurement of cartilage intervals, okay? And these are just a few examples in the spine and the upper and lower extremities. So the point is, the X-rays are required. Well, if you agree to that and you agree to adopt that as your new operating principle, the next principle is that many times in the process of reviewing the X-ray studies, you will come up with findings, or perhaps the medical radiologist will describe findings to you that require medical research in order to understand the significance of the findings on the examinee's condition and on the examinee's particular circumstance as it relates to the disputed issues involved with the permanent impairment evaluation. And in this program, in sessions 2, 3, and 4, we went over several examples as to how the X-rays revealed fascinating findings that could otherwise never have been detected without ordering the necessary diagnostic studies. And we showed how those interesting and fascinating findings went on to change the entire complexion of the case. And I shared with you the qualified medical evaluator's opinions and conclusions exactly as those opinions and conclusions appeared in the qualified medical evaluation report. Okay, so in today's discussion, I have another fascinating discussion for you. It has to do with a lower extremity injury case. And in the process of assessing the lower extremity for post-traumatic arthritis of the knee, X-rays revealed some fascinating findings related to patellofemoral pain that impacted the opinions and conclusions in a profound way. And I want to share that with you, and I'm sure you will get a jaw-dropping moment when you get to that point in today's discussion. So with no further ado, let's begin today's discussion, which is focused on patellofemoral pain and issues related to patellofemoral instability. Okay, so today's case involves a 55-year-old female. She is currently a high school teacher, and she suffered a non-industrial fracture of her right ankle. Now, this image here does not depict the right ankle, it depicts here the left ankle. But let's just imagine that's the right ankle with a walking boot on the ankle with surgical hardware to stabilize fracture fragments of the distal fibula. Okay, so in order to ambulate around the campus as a high school English teacher, she was prescribed an orthopedic scooter. So this is an image of an orthopedic scooter. I'm not sure if this is the exact scooter that she had, but she had a similar scooter to this. And she was scooting around the campus one day when one of the front wheel tires got caught in a defect in the concrete sidewalk. And she went over the top of the handlebars, according to her, and she landed on an outstretched hand, also striking her right knee, same knee, or the knee right above the ankle fracture, and she struck her knee on the ground on what she described as the raised edge of a metal plate. You've seen those metal plates supposedly flush in the concrete. Well, she claimed that it was a raised edge of a metal plate, and she suffered injury to her right knee, among other body parts. So in today's discussion, we're going to focus on the assessment of the right knee and the opinions and conclusions regarding permanent impairment and apportionment for the right knee. So over the next several weeks, she received medical treatment for her injured body parts, including the cervical spine, the right shoulder, the right wrist, and the right knee. And over the next several weeks, it seemed that right knee pain symptoms were reluctant to resolve. And so the primary treating physician ordered an MRI study of the right knee. And here are the findings as described by the medical radiologist. So let's go over these findings in great detail, because these findings we're going to refer back to these findings later when we perform our own X-ray studies as a part of the QME evaluation. So the medical radiologist described that the anterior and posterior cruciate ligaments are intact, as are both the medial and lateral collateral ligaments. All 4 ligaments, stabilizing ligaments circumferentially around the knee, are intact, as well as the insertion of the popliteus tendon is intact. There is fluid in the infrapatellar fat pad. This is also known as Hoffa's fat pad. This is going to become significant later on, and this here is a telltale MRI finding, telltale finding for another condition of the knee, which is going to be relevant to the opinions and conclusions of this particular report. The patellar tendon and quadriceps mechanism are intact. There are several subchondral cysts deep to the posterior cruciate ligament at the posterior tibial plateaus. There is no significant suprapatellar joint effusion. Patellofemoral alignment is maintained. Bone marrow signals are otherwise unremarkable. There is minimal prepatellar subcutaneous edema. There is a small popliteal cyst. There are small patellofemoral osteophytes. There is mild cartilaginous thinning at the patellofemoral joint, but the femoral tibial cartilage is grossly intact. So the impressions are a small popliteal cyst, a small amount of fluid anterior to the intercondylar notch, and mild degenerative changes at the patellofemoral joint and subchondral cyst at the posterior tibial plateau, deep to the posterior cruciate ligament. So these findings describe some early degenerative changes and also some painful conditions, not otherwise unexpected in a 55-year-old female. And I should tell you that this particular 55-year-old female, up until just a few years prior, basically up until the date of this industrial injury, was an avid and dedicated distance runner, even running several marathons throughout her 30s and 40s and even into her early 50s. So these are knees that have a lot of miles on them, and so these are describing some minimal degenerative changes and other painful findings, such as fluid in the infrapatellar fat pad, fluid in Hoffa's fat pad, which is associated with fat pad impingement, and that is a painful condition. And this fluid in the infrapatellar fat pad is something that we're going to see rear its head later on that's going to impact our opinions and conclusions. Okay, so then she presented to the qualified medical evaluator for his evaluation, and let's go over those physical examination findings. On physical examination, the examinee presented to the evaluation with a pair of rigid orthotics stuffed in her casual sandals, casual open-toe, no socks sandals. And on inspection, her foot position within these orthotics and on top of these sandals looked to be quite contrived and quite uncomfortable. And she stated that she had been prescribed these orthotics by a podiatrist. On inspection of the feet, on the right foot, she had 3 surgical scars. There was a scar at the first metatarsal phalangeal joint due to a prior bunionectomy. She had a scar on the 5th toe due to hammer toe correction. And then she had a surgical scar over the lateral malleolus which is the subject of the surgical stabilization for the distal fibula fracture, which caused the need for the orthopedic scooter, which led to this industrial injury. On the palpation examination, on the right knee, she had pain to palpation of the medial tibial plateau, the medial femoral condyle, the medial patellofemoral ligament, and the medial meniscus. In other words, the medial aspect of her knee in and around the joint line was all tender to palpation. There was a mild jump sign to moderate palpation pressure, and she described this as the bullseye of the location of her right knee pain. So she was complaining of medial right knee pain. On the right ankle and foot, there was a surgical scar over the lateral malleolus. Surgical hardware was palpable just beneath the skin, with one particular surgical screw being very close to the surface of the skin above the lateral malleolus. This is due to implanted surgical hardware to stabilize the fibula fracture. There was a report of slight pain to palpation of the lateral malleolus, the dome of the talus, and the inferior tibiofibular joint. There was contracture of the proximal interphalangeal joints of the second, third, and fourth toes. Those are known as hammer toes. And there has been a surgical procedure to correct hammer toe of the fifth toe. So based on this physical examination, you can begin to conclude that her right foot is an issue. She's had at least 3 surgical procedures on the right shoe, and she's been prescribed some type of prescriptive corrective orthotics to correct posture and malalignment, at least of the right lower extremity, possibly as a sequelae to the hammer toe and bunionectomy surgical procedures. The point is that the right foot may apparently be involved in the genesis and continuation of right knee pain. So here are some pictures of those findings. Here is the scar at the lateral malleolus, and you can see that right about here there's a surgical screw very close to the surface of the skin, which is tender to palpation, and then the surgical hardware itself is implanted approximately like so. So there's a scar there, and there's some edema here that you can notice right below the lateral malleolus here, right below the anterior talofibular ligament. Here, there's been a surgical procedure to correct bunionectomy, and there's a surgical scar right through here. If you can see it, I'll draw an arrow toward it right there on the other side of the circle. And then the fifth toe here has had a hammer toe correction. And you can notice that the second, third, and fourth toes are already deformed into hammer toe deformity. So this right lower extremity, this right foot and ankle, has some issues. And let's see how those issues relate to her ongoing complaints of right knee pain. Finishing up the physical examination, the range of motion of the knee was full and complete and without report of pain. Strength to resisted manual muscle testing was +5 in resisted flexion and resisted extension. And resisted flexion was tested in 3 positions, and resisted extension was tested in 5 positions. And all of those had impressive strength, at least to manual muscle testing. Ligament testing was consistent with the findings on MRI, with no findings for laxity or pain circumferentially around the knee, and there were no findings on meniscus testing, such as McMurray's testing for the medial and lateral menisci. On patellar apprehension testing, this testing was positive for a report of pain and also for the objective finding of apprehension of patellar dislocation, and she pointed to the medial kneecap as the source of her pain. So all signs seem to point to the medial aspect of the knee. And the qualified medical evaluator concluded that the structure that she was indicated when she pointed to the medial aspect of the knee was the medial patellofemoral ligament. And that's a structure that when it's been injured and fails to recover properly can develop laxity and can contribute to patellar instability. So we're starting to see a clinical picture of a normal knee, at least to structural integrity and meniscus testing. The knee is normal, but there seems to be some aspect of patellofemoral involvement as the source of this particular examinee's complaints of right knee pain. And because Chapter 17 requires the assessment of post-traumatic arthritis in all lower extremity cases, whether the injury involved the hip, the knee, the ankle, or even the joints of the foot, post-traumatic arthritis is one of the impairments that examinees can suffer after a traumatic injury. And because this examinee did suffer a traumatic injury to the knee, the qualified medical evaluator rightly ordered the diagnostic x-rays of the knee. And here are the findings as described by the medical radiologist. The medical radiologist tells us that the medial and lateral joint space compartments are maintained. Medial and lateral joint space interval on the A to P and the patellofemoral interval on the merchant view measures 4 millimeters. So let me translate that for you. He tells us that the medial joint space is 4 millimeters. The lateral joint space is 4 millimeters. Those were both measured on the A to P radiograph. And the patellofemoral interval, which is measured on the merchant view, also measures 4 millimeters. Now, we're going to see by reference to the AMA guides, these cartilage intervals are well within normal limits and do not qualify for permanent impairment. So, at least according to the medical radiologist, this particular examinee does not qualify for permanent impairment due to post-traumatic arthritis because the cartilage intervals are well within normal limits as described by the AMA guides. There's no evidence of a joint effusion. There is, however, minimal lateral translation of the patella at the patellofemoral joint with small lateral patellar osteophytes. So now we're starting to see some clinical findings come together where the MRI, where the physical exam, and now where diagnostic x-rays are starting to paint a picture of patellofemoral involvement. And this is turning into less and less of a knee joint proper case and more of a patellofemoral case. There is small, stable patellar osteophytes at the upper and inferior pole of the patellofemoral joint. No fractures, soft tissues are intact. There are minimal degenerative changes at the patellofemoral joint. So we would expect perhaps minimal degenerative changes at the patellofemoral joint in a chronic distance runner. So these findings are not significantly out of normal range for what we would expect for a 55-year-old female. But during the course of reviewing these x-ray studies for the assessment of post-traumatic arthritis, some interesting findings were recorded. And it's the interesting findings more so than the cartilage interval measurements that are going to contribute to this particular examinee's permanent impairment rating. And we'll go over that in just a couple moments. But let's just review what the AMA guides tell us about these cartilage interval measurements. So here is table 1731 from the AMA guides, and this is the table that we refer to for our normal and abnormal values of cartilage interval measurements. Now I have this table cropped off just to show cartilage interval measurements associated with the sacroiliac joint, with the hip joint, and then with the 3 compartments of the knee joint. So with regards to the knee joint, table 1731 tells us that the normal cartilage interval of both the medial and lateral knee joint is 4 millimeters. 4 millimeters. They give us our normal range of values here in this column. In these columns, they tell us what is the permanent impairment rating associated with diminished cartilage intervals or with diminishing cartilage intervals. So the first permanent impairment rating is provided when the cartilage interval is reduced to 3 millimeters. We don't have a permanent impairment rating for a 3.5 millimeter cartilage interval or a 3.8 millimeter cartilage interval, but when the cartilage interval diminishes to 3 millimeters, then we provide for 3% whole person impairment. If the cartilage interval diminishes to 2 millimeters, that qualifies for 8% whole person impairment, and etc. And the chart reads in this direction, with diminishing cartilage interval associated with a higher permanent impairment rating due to arthritis of the knee joint. Now for the patellofemoral joint, they do not provide us normal values of the cartilage interval of the patellofemoral joint, but Table 1731 tells us that the examinee does not qualify for permanent impairment until the cartilage interval reaches 2 millimeters or less. At 2 millimeters, the examinee qualifies for 4% whole person impairment, and the whole person impairment increases as the cartilage interval diminishes. So we know from this particular table that the AMA guides consider a cartilage interval of 3 millimeters for the patellofemoral joint to be normal because there is no permanent impairment rating associated with a 3 millimeter cartilage interval measurement. Well, the medical radiologist in this case, he measured the cartilage interval of the patellofemoral interval, and he found the cartilage interval to be 4 millimeters. So that does not qualify for permanent impairment, and neither of the other two measurements of the medial or the lateral joint qualify for permanent impairment, at least due to post-traumatic arthritis. So as far as the AMA guides are concerned, and as far as our permanent impairment evaluation is concerned, we've done our job now on this examinee in that we've assessed the examinee for post-traumatic arthritis, and we've concluded that she does not have impairment due to post-traumatic arthritis. However, on evaluating these X-ray studies, we come up with some interesting findings that in themselves may qualify the examinee for permanent impairment and may affect the apportionment determination for that permanent impairment. So let's go over that in the next several slides. Okay, so here are the X-ray images, and let's just go over these cartilage interval measurements so you understand how to do them and that you conclude, like I have, that it's both easy and fun to do. So here's the A to P right knee. Here's the sunrise or the merchant view of the right knee. To measure the cartilage intervals, we just pull down one of our measuring tools, such as measure length. Find a measurable point on the tibial plateau. Measure up to the medial femoral condyle and just record the distance. And that line looks to be about 5.7 millimeters. The medical radiologist described it as 4 millimeters. Let's check out the lateral joint margin. Measure that. That appears to be approximately 3.91 millimeters. The medical radiologist described it as 4 millimeters. So we're within the same ballpark as to the measurements as described by the medical radiologist. For the patellofemoral articulation, again, find a measurable interval on the tibial sulcus here. This is the known as the trochlear groove here. So let's just measure from the medial condyle up to the medial patellar facet, and we're getting a measurement of approximately 4 millimeters, 4.24, and then up to the lateral facet. This is approximately 3.17 millimeters. So all of those measurements are within normal limits as described by the AMA guides. Now in your report, when you present the findings of your cartilage interval measurements to the reader of the report, it's always helpful to present those findings in the format of a table. So here's a table that you can adopt for use in your own report. And here you provide the reader of the report the joint that you're assessing. This is the medial tibial-femoral joint. We also do the lateral tibial-femoral joint, and then also the patella-femoral joint. And you provide the reader of the report with the findings of your measurements. And the patellofemoral measurement here. And then you give the reader of the report the AMA guide's normals, so that the reader of the report can compare the examinee's findings with the normal findings described in the AMA guides. Now, because this particular examinee was negative for post-traumatic arthritis, but was positive for subjective complaints of patellofemoral pain, was positive for physical examination findings consistent with patellofemoral instability, and was consistent in MRI and at least the medical radiologist description of minimal degenerative changes of the patellofemoral joint. So medical research on the patellofemoral joint pain and patellar instability became necessary. I'm going to show you how this medical research was pivotal in arriving at the opinions and conclusions of this case. So the medical research in this case consisted of 4 references, and they're listed here in the body of the report for the reader of the report. Medical research was conducted in Yoakum and Rose, Essentials of Skeletal Radiology, was conducted in some online searches at orthobullets.com. The qualified medical evaluator was able to locate a study from the Physiotherapy Practitioner Journal related to Patella Alta. And then also the qualified medical evaluator relied on the findings of another study published in the American Journal of Röntgenology related to Hoffa's fat pad edema, which was described in the original MRI report. And there's going to be a fascinating discovery associating patellofemoral dysfunction with impingement and edema of the Hoffa's fat pad, which is going to play out in the opinions and conclusions of this report. So let's go through these medical research references one at a time and develop the opinions and conclusions in this case. So according to the medical research conducted at OrthoBullets tells us a little bit about the epidemiology of patellar instability as it relates to patellofemoral pain and patellofemoral degenerative changes. And OrthoBullets tells us that this patellar instability occurs most commonly in the 2nd and 3rd decades of life. So that doesn't particularly relate to our examinee who's in her 6th decade of life. OrthoBullets tells us that the risk factors for the development of patellar instability has to do in general with generalized ligamentous laxity associated with some congenital conditions, is associated with a prior patellar instability event such as a patellar subluxation or a patellar dislocation. It's also associated with what's known as the miserable malalignment syndrome, which is a term named for the 3 anatomic characteristics that lead to an increased Q angle at the knee. And we know that women have an increased Q angle at the knee compared to men. So 3 anatomic characteristics have to do with femoral anteversion, and we did not measure femoral anteversion in this particular examinee. Genu valgum, and we did not measure genu valgum in this particular examinee. In fact, the AMA guides do not require a measurement of the Q angle of the knee except in those cases that involve a knee replacement. And this examinee was not involved with a knee replacement. External tibial torsion and pronated feet will also contribute to an increased Q angle at the knee. And we know from our examination of the examinee, she had pronated feet. In fact, she had corrective orthotics for the correction of overpronation of the feet. So here's at least one risk factor related to our particular examinee. Some anatomic factors that place the examinee at risk for patellar instability include some osseous malalignment findings, such as trochlear dysplasia and such as patella alta. So this is where the medical research guides our evaluation of this examinee. We're now going to take these findings from the medical research and we're going to assess the x-rays for the presence of patella alta, and we're going to assess for the presence of trochlear dysplasia. This is the femoral trochlea, the groove through which the patella slides up and down. When the examinee has patella alta, this causes the patella to not articulate with the femoral sulcus, which then causes a loss of constraint or a loss of restraint of the femoral sulcus on the patella itself as the patella tracks up and down in the femoral sulcus. Okay, so let's now take a look at these x-rays and do some assessments for patella alta and some assessments for trochlear dysplasia. So how do we assess for patella alta and how do we assess for for trochlear dysplasia? Well, medical research in the radiology reference Yoke-Monroe tells us exactly how to do it. Now, these are the type of evaluations that you're not expected to know as a general practitioner or even as an orthopedist or even as a chiropractor. These are specific and precise evaluation procedures that any evaluator would be required to research prior to being able to conduct these specific evaluations. So this is bona fide and appropriate medical research for the resolution of disputed issues in this case. So for the patella alta evaluation, we know that this is a risk factor for patellar instability according to our prior medical research. This reference tells us that we need to measure the length of the patellar tendon, which is the distance between the insertion points of the posterior tendon surface at the inferior patellar pole and then below at the notch at the tibial tubercle. That gives us our patellar tendon length. And then we're going to find out the patellar length itself, the length of the patella, which is the greatest diagonal dimension between the superior and inferior poles. Once we know those two lengths, we can then create a ratio of the length of the patellar tendon to the patella itself and assess that ratio. That ratio should come in somewhere between 0.8 and 1.2. Now, if the patella tendon and the patellar length were exactly the same, the ratio would be 1. If the patellar tendon is a little bit shorter than the length of the patella itself, the ratio will be less than 1. If the patella tendon is longer than the length of the patella itself, the ratio will be greater, such as 1.2 or even higher, with higher ratios in this direction indicative of patella alta and lower ratios in this direction indicative of patella baja. So we know that patella alta is associated with patellar instability, and we now are going to assess our examinee's x-rays using these particular descriptors. Then we're going to do several other assessments to assess for trochlear dysplasia. We're going to do a patella alignment evaluation, such as measuring the patellar apex. Normally, the patella is centered when its apex is directly above the deepest section of the intercondylar sulcus, and I'll show you that. We're going to measure the sulcus angle to determine if this examinee has trochlear dysplasia. The normal sulcus angle is 138 degrees plus or minus 60 degrees. So that's a range of 132 to 144 degrees. With larger angles, such as 144 or 150 or 160, indicates a shallower intercondylar groove, which predisposes the individual to both subluxation and dislocation. And then finally, we're going to measure the lateral patellofemoral angle, which is aligned tangential to the femoral condyles, which is then intersected by a line that joins the limits of the lateral patellar facet. This angle should normally open laterally With patellar subluxation, the lines are either parallel or would open medially, and that would be suggestive of some pathologic tilt of the patella. Okay, so let's take a look at these in a little more detail. So here are the views that we're going to use for our assessment of patella alta and for trochlear dysplasia. We'll use the lateral view for the assessment of patella alta, and we'll use the sunrise view for the assessment of trochlear dysplasia. So the first assessment that we want to do for patella alta involves making a measurement of the length of the patella itself, which goes from its greatest diagonal distance from the superior pole to the inferior pole, and you'll notice I've cut out just a little distance superiorly to account for the superior patellar osteophyte, and we come up with a measurement here of 39.60 millimeters. 39.60, and I'm recording that here so that we can perform our calculation. So that's the patellar length, and then the patellar tendon length goes from the posterior articular surface of the patella here to its insertion on the tibial tubercle here, and we're coming in at approximately right about there, approximately 58.88. So if we take a ratio of the length of the patellar tendon, which is 58.88, and divide it by the length of the patella, which is 39.60, we get an insole ratio of 1.48. 1.48 is our insole ratio. Well, our first reference from Yoke-Monroe told us that the normal range of insole ratio is 0.8 to 1.2. So this is indicative of a longer than normal patellar tendon and a high riding patella within the trochlear groove. This is referred to as patella alta. So according to OrthoBullets, one of the risk factors, one of the anatomic variant risk factors that predisposes to patellar instability is patella alta, and we have confirmed indeed in this examinee, the examinee does indeed have patella alta, okay, with an insole ratio far outside the normal limit of 1.2. Her ratio is 1.48, okay? Well, what about trochlear dysplasia? Does this examinee have trochlear dysplasia? Well, the first thing we assess for is the patellar alignment, the patella apex, where the patella should be centered with the apex of the patella here directly above the deepest section of the intracondylar sulcus. So here is the intracondylar sulcus. Here, I have my mouse pointed on it, and the apex of the patella is right there. So would you say that the apex of the patella is centered over the deepest part of the intracondylar sulcus? It looks like it is. So the medical radiologist describes slight lateral positioning of the patella within the trochlear groove, but by this measurement, the patella seems to be fairly well situated within the trochlear groove. So the patellar alignment seems to be within normal limits. If there is any misalignment, it's subtle at most. Next, we want to measure a sulcus angle. So we do that by measuring along the trochlear groove here, both the borders of the trochlear groove to the intercondylar sulcus. Like so. And this is a measurement of approximately 128 degrees. So according to one of our references, the normal value is 132 to 144 with higher angles higher more towards 180 degrees, suggestive of patellar instability. This is therefore a steeper than normal range value. It may be suggestive of a slight trochlear dysplasia in this particular examinee. And then finally, we have our lateral patellofemoral angle, where we draw a line across the two femoral condyles here. And then we create a line tangential to the lateral patellar facet here. And that angle should open laterally, which is what it's doing over here. In cases of patellar subluxation, that angle will, these lines will be more parallel, or the angle will open medially. So this is indicative of a normal lateral patellofemoral angle, which tells us that the patella is normally situated within the patellofemoral groove, at least in this particular view. So these x-rays tell us that the examinee does indeed have bona fide radiographic findings for patella alta, and has possibly at least one suspicious finding for trochlear dysplasia. So here is a pictorial representation of various positioning alignments of the patella, with the ideal or perfect patella with an insole ratio of 0, being depicted here in this diagram, with increasing patella baja in this direction, meaning increasingly shorter and shorter patellar tendon lengths, and increasing patella alta in this direction, meaning increasing length of the patella tendon. I'm sorry if I said increasing tendon length in this direction. The tendon length actually decreases in patella baja. Well, our particular examinee had an insole ratio of 1.48, so that would put her somewhere between these two depictions of the position of the patella. Here's an insole ratio of 1.31, and here's an insole ratio of 1.52. So she would look roughly about like this, with a high riding patella within the patellar groove, within the trochlear groove. Well, this is a biomechanical fault that changes the load transfer and weight bearing transfer and force characteristics of the patella, and can be a source of pain. And this pain can manifest itself in the form of imaging findings, which we're going to get to in just a few minutes, associated with Hoffa's fat pad. So let's see what the additional references in the medical research have to tell us about the association of patella alta and patellar instability. Well, our third reference in physiotherapy practitioner gives us some epidemiological statistics related to patella alta, and it tells us that patella alta has been shown to be associated with chondromalacia of the articular surface of the patella and pain. Now, in this examinee, we did not find chondromalacia. We found normal cartilage interval measurement, but she did have some physical examination findings for patellar apprehension and patellofemoral pain. So it could be that this examinee has some, at least subclinical, ongoing chondromalacia of the patella. Patella alta has also been implicated in patellar osteoarthritis, and we do have MRI and X-ray findings for patellofemoral arthritis in the form of inferior, lateral, and superior osteophytes on the patella. This reference tells us that the prevalence of patella alta in individuals with patellar osteoarthritis was 6 times that of individuals with normal patellar articular cartilage. Additionally, some other studies reported that subjects with anterior knee pain demonstrated a significantly more superior patellar position in the affected knee relative to healthy control knees. So this examinee we've identified has patella alta. She has radiographic findings for patella alta. She has clinical findings for patellofemoral pain, and she has subjective complaints of patellofemoral pain. So you're starting to see a picture where this examinee's patellofemoral pain has more to do with pre-existing conditions of the knee, perhaps than due to the industrial injury. So while this examinee may qualify for a permanent impairment rating due to patellar instability, that permanent impairment rating will be subject to some portion of apportionment due to pre-existing condition of patella alta. So we have some findings for patellofemoral involvement due to patella alta. And we also, on the prior MRI studies, we had several other significant findings, such as some cysts in the posterior cruciate ligament. There was some edema noted in the infrapatellar fat pad, and there were some other findings as well. Well, can these findings all be tied together? Is there some condition that can explain the conglomeration of all of these findings? Well, this particular study in the American Journal of Röntgenology seemingly ties together these otherwise disparate appearing imaging and physical examination findings. So they conducted a study to find out if there was any association between the condition of patella alta and the MRI imaging finding of edema in the infrapatellar fat pad, also known as Hoffa's fat pad. So they tell us that non-elderly patients, such as this patient at 55 years of age, who present with knee pain often have patellofemoral maltracking, such as patella alta, or impingement abnormalities. But there's a relative shortage of literature on the incidence and significance of impingement-related edema of Hoffa's fat pad in these cases that involve maltracking or impingement abnormalities. Therefore, our study was designed to systematically evaluate the correlation of Hoffa's fat pad edema with various anatomic parameters of trochlear morphology and patellar alignment, such as associated with patella alta. So what they did is they evaluated 50 knee MRI examinations in 47 patients for the presence of edema in Hoffa's fat pad, and then they took those examinees who had edema in Hoffa's fat pad and they did assessments to assess for trochlear dysplasia and or patella alta, which is known as an anatomic abnormality of the patellofemoral joint. Okay, so what did they find? The findings of the study were as follows. Of the 50 examinations, 50 MRI films studied, 50% of those showed fat pad, Hoffa's fat pad edema. And statistically significant differences were seen between those with and without edema with respect to sex, with more women showing edema in Hoffa's fat pad than men, and also significant differences with respect to patellar tendon to patellar length ratio for those with and without edema respectively, whereas those with a insole ratio of greater than 1.3 had a higher incidence of edema in Hoffa's fat pad than those with an insole ratio closer to 1. And they concluded that the findings in our study suggest that edema in Hoffa's fat pad may be an important indicator of underlying patellofemoral maltracking or impingement in younger symptomatic patients. So here we have a study that shows that due to this anatomic configuration of a patella alta, this patella alta contributes and is associated with impingement of Hoffa's fat pad. Impingement of Hoffa's fat pad is a pain-generating condition that shows up as an edematous fat pad on MRI studies. So this indicates that this examinee's particular pain symptoms seem to be associated with a pre-existing condition of patella alta. Okay, so let's take a look at this Hoffa's fat pad, and then we'll bring the opinions and conclusions of this case to a close. So here's an image representation of Hoffa's fat pad. So Hoffa's fat pad is here, and Hoffa's fat pad is an intracapsular structure, whereas the patellofemoral articulation is extracapsular. But this intracapsular structure can be irritated by the extracapsular patellofemoral mechanism. And when the patella has a patella alta configuration, it creates an impingement condition here on the superior aspect of the Hoffa's fat pad. And that shows up on the MRI images of edema in the infrapatellar fat pad. So just to review the findings in this case so far, we found that the patella alignment, at least on the Merchant view, was within normal limits. We found that the sulcus angle was within normal limits. Well, was slightly diminished, but of unknown significance because it was within 6 degrees of the normal range. And then the lateral patellofemoral joint lines did have an angle that opened laterally. So we found that that was within normal limits. And any findings for trochlear dysplasia are suggested at most and not definitive at best. But the most definitive finding was that of patella alta. So based on that, the qualified medical evaluator provided a permanent impairment rating for this particular examinee. And here is the qualified medical evaluator's permanent impairment rating. He stated that with relation to arthritis of joints, and by analogy to arthritis of joints, applies to Mrs. Jones due to findings of patellar instability. According to Table 1733, this qualifies for 3% whole person impairment. Here is a snippet taken from Table 1733, which tells us that in cases with patellar instability, the examinee qualifies for 3% whole person impairment. Now, because this patellar instability is due in some measure to pre-existing non-industrial condition of patella alta, this permanent impairment rating is subject to some portion of apportionment. So let's review the qualified medical evaluator's apportionment argument. So in the apportionment section of the QME report, the qualified medical evaluator provided the following opinion. For the permanent impairment related to the right knee, in my opinion and within reasonable medical probability, 0% of the permanent impairment is due to the industrial injury and 100% is due to other factors. And then the qualified medical evaluator supports this opinion and conclusion with the following reasons. He states that with the industrial injury on March 3, 2015, Mrs. Jones suffered a contusion injury without internal derangement of the right knee. He concluded that it was without internal derangement because the MRI report described normal integrity of the menisci and normal integrity of the cruciate and collateral ligaments. So he concluded that it was a contusion injury without internal derangement. And he explains that by saying that the MRI studies obtained shortly after the injury demonstrated pre-existing degenerative changes of the patella. Now, the knee contusion injury healed quickly. But now, Mrs. Jones continues to report ongoing symptoms with the right knee. In my opinion, those symptoms are due to gait compensation following 3 right lower extremity surgical procedures to the great toe bunionectomy, small toe hammer toe repair, and right fibula internal fixation with surgical hardware. These changes to the foot are causing slight gait derangement during stance phase. This affects the knee, causing patella instability during knee flexion and early stance and late swing phases of gait. This is due 100% to other factors, including the fact that the examinee has a pre-existing condition that predisposes her to patellar instability due to patella alta. But in this particular case, these further problems, these further biomechanical gait compensations due to 3 surgical procedures and installation of rigid orthotics cause a slight gait derangement of gait that quickly causes this pre-existing asymptomatic condition of patella alta to be constantly and ongoingly symptomatic. And in this qualified medical evaluator's opinion, this is due 100% to other factors and is due 0% to the industrial injury. So doctors, isn't that a fascinating case? This is a fascinating example as to how medical research contributed to the qualified medical evaluator's opinions and conclusions on permanent impairment and on apportionment of the permanent impairment. In this particular case, the qualified medical evaluator did find that the examinee has a bona fide impairment of the knee. The examinee has bona fide patella alta instability of the knee. And the qualified medical evaluator demonstrated through the use of medical research that patella alta in itself is a painful condition. And he opined that the patella alta was neither exacerbated nor aggravated by the industrial injury. However, the patella alta has become increasingly exacerbated and aggravated by the examinee's increasing gait disturbance due to pre-existing non-industrial conditions, mostly with the right foot, especially most recently the internal fixation of the right ankle with surgical hardware. So had you had this case and had you conducted medical research, you may have opined differently. However, this examiner's opinions and conclusions are consistent with the mechanism of injury, which simply involved a contusion injury to the right knee without internal derangement and without apparent major subluxation or dislocation of the patellofemoral articulation. And so this particular examiner's opinions and conclusions flow well from the history of the injury to the history of the medical treatment and the progression through medical treatment after the injury. It flows well with the findings of the initial MRI studies. It flows well with the findings of the examiner's physical examination and the examiner's diagnostic studies. And it flows well with the philosophy of the medical research that the examiner conducted related to patella alta especially. And secondarily, he tied in the finding of patella alta with the MRI finding of edema in the infrapatellar fat pad, also known as Hoffa's fat pad. So you may have opined differently had you conducted different medical research. My review of this case is that the medical research that this qualified medical evaluator did exactly supported his opinions and conclusions, and his opinions and conclusions flowed naturally from the medical research. So this is a brilliant case that brilliantly demonstrates the future of qualified medical evaluation reports. We talked earlier that the future, at least as far as if the Division of Workers' Compensation gets their way, future qualified medical evaluation reports will be required to include medical research, at least to qualify for the highest billing level, the ML104 billing level. So it seems that the Division of Workers' Compensation will favor reports that include medical research, and this case perfectly illustrates how medical research is critical for arriving at accurate opinions and conclusions that can be arrived at in no other way. Can you imagine QME providing opinions and conclusions simply by stating, in my opinion and based on my 35 years of experience? That doesn't hold a candle to this case, where the qualified medical evaluator cited 4 references and extracted key data and relevant principles from 4 references and then tied them all together with an opinion and conclusion that is irrefutable. So doctors, I hope this helped you, and I hope you take this suggestion to heart to include medical research when appropriate into your very next evaluation. So I want to thank you for taking the time to join me on today's video. Look forward to being with you on our next video, where we conclude this program with x-rays of the spine, and we review some measurements for the assessment of permanent impairment of the spine. So I want to thank you for being with me today, and I look forward to being with you on our next session. And for now, I'm wishing you best of success in your career as a qualified medical evaluator.